I'm your host, Dr. Risa Ravitz, and I'm not your average neurologist. My interests and passions run deep, and I'm constantly pushing myself to find truths. I'm a medical doctor, a woman, a surfer, a runner, and an exerciser, and an avid reader of all topics. It's not easy to sift through all this information, and there's many podcasts out there. So let's try to get through this together. Welcome, everyone. Welcome to the Ravitz Way again. I am very, very excited to introduce a colleague and a friend from way back. This is Dr. Nick Saikali. Did I do it right?
Yeah.
All right, good.
It's so hard to pronounce.
It
this
is.
Lovely last name with so many
different vowels.
So many different vowels,
Yeah.
But thank you.
Yeah. So we actually know each other because we studied for the neurology boards together, which was such an awesome experience. It was not great. And actually they changed that now, so we don't have to do this 2-week course. And how long was the test? Maybe 4
hours.
4 hours, 260 some odd questions about neuroanatomy that you probably remember and I don't.
Yeah.
But why don't you tell us a little bit about your journey after that?
No, thank you. Thank you for having me here.
You're welcome.
I appreciate it.
Excited.
It's so nice seeing you again. It's just a crazy story how I'm visiting your office, all the way from Buffalo, coming to New York City and talking to neurologists who specialize in headache medicine. And I'm sitting in your office and just love to tell the story. I tell all the time. I even tell to patients just so they can look you up and see how cool you are. But
thank you.
But it's, we of course, hit it off in the office talking about migraines and asked for each other's number just so we could get together and do this on today's date. And we both look in the phone and say, wait, we have each other's number. And then we start wondering, what night was that? But it wasn't. It turned out, thank God, I keep notes, and I saw that we studied for the boards.
So you put neurology. Me as Risa Ravitz study with the boards together?
Study of boards in Philly. We studied, yes, in Philly.
Okay. I gotta start doing that. That's a good idea.
That's what I put notes in there of how I meet people, because that was 18 years ago. 18 years have gone by.
Wow.
And you look the same.
So do you?
Yeah, thanks. Just a little gray hair. A couple kids do that. Wife does it more. But it's great being here. I'm so excited to be on the show and give you a little bit of background on myself. I am a neurologist, board certified in neurology and in headache medicine and in neuroimaging. Lucky enough to be board certified and trained in fellowship at Buffalo, New York, at the Dent Neurological Institute. And I am a partner at a private neurology group, one of the largest private neurology groups in the country. I specialize, as I said, in headache medicine and neuroimaging, but mostly see patients day in and day out and go lecture about headache disorders, mostly about migraines, of course, and see about 100 to 120 patients a day at the headache clinic.
Wow.
With my with the PAs and NPs that I'm lucky enough to be a part of team of. And so we tend to see anywhere from 400 to 500 patients a day for coming in with headache disorders.
Wow. So so I think people don't realize, one, how many people have headaches and migraines, which is crazy. These are crazy numbers, and there's still a ridiculous shortage of neurologists and specifically headache doctors. And I also found, I love what I do, and it sounds like you do too, specifically headache medicine, specifically neurology as well. But a lot of my colleagues, I don't know if you've noticed this, they went into a different field of neurology, but their bread and butter is actually migraine and headache because there's so much of it. So you're doing amazing work, and
As are you.
I think we have to keep fighting the good fight.
Yeah, we when we first started in headache medicine, because we graduated at the same time. But looking in the U.S. population, it was around 8 million Americans suffer with migraines.
So
where are we at right now?
Yeah, so it was 2009. So the audience of 2010, 8 million. We're now at, I
40
think,
plus.
I think I've heard even higher numbers for episodic, 50 million. Yeah, 50 million people, and I think that number is going to keep going up as people are more aware and doctors diagnose and people are aware of what they're actually feeling, right?
Yeah, and we have, in my opinion, great medications that have come out not just being efficacious, but more tolerable, right? I mean, that's the biggest thing
Absolutely.
of therapy and medicine is, you have to think of not just how well they work, but how tolerable they are, and decreasing the drug-to-drug interactions, right?
Yes.
Unfortunately, we have a lot of comorbid conditions that we suffer with in the U.S. population, that primary care has a hard time just dealing with headache or migraine patients, and how many other disease states the patients have with diabetes, hypertension, and these are conditions
Depression,
that require
a lot of these things.
depression,
So
especially, right?
I agree. So the new medicines they're amazing. I agree.
Yeah.
They're really good. 'Cause
So-
easy to prescribe, well tolerated, and work well.
Yeah.
So I'd love to ask you, neuroimaging is, that's amazing that you did that too. You just were bored and wanted to, no, I'm just kidding. You just wanted to learn more, and which is awesome. So let's dive into that a little bit, because patients are always asking me about that, and it's very cool. So let's start very basic. So difference between for the patient, the layperson, CT versus MRI for headaches. Let's start with that.
Yeah.
Yeah.
So there's a lot to be said. I mean,
Yeah.
I could go on forever talking about it, but I will tell you, majority of patients who have a typical kind of a migraine don't need any kind of imaging. That's one. But two, there's, that medical legal kind of aspect to where
Yes.
that brings us into the question of why didn't they get imaging when they came in with a headache, and how do you know for sure it's a migraine? So there's a lot of questions to be said, but a lot of patients who have had a headache that one hasn't gone away, or just different. We could talk about red flags in the future, like in
For sure,
just
for
in
sure.
a minute. But one thing that they go to is urgent care centers, much easier nowadays than going to an emergency room, and most of them have just CAT scans.
Yeah.
So
Well, because CAT scans are fast, they're readily available. It takes 3 minutes to do that, or less than that, 30 seconds to do it.
CAT scan. And CAT scans, the problem with CAT scans, there's goods and there's bads, of course, with everything. And it's great to have the technology. We were the fourth center in the world, in the U.S. to have a CAT scan. In Buffalo, and so we know about CAT scans. We utilized them a lot before MRIs were well known and easily accessible. But I remember training in London, and the CAT scan was the only thing they had at the hospital that would come once a week. So whoever needed a CAT scan of any sort in Europe, in London, where I trained, of course it was a long time ago, would only be able to get a CAT scan. There was no MRI, so it's scary. And that was
It is, but
2008.
do you remember our attendings were telling us about pneumograms, which was basically like a head x-ray, which would show just like bone and air and maybe some shift. They would tell me about it all the time, and I was like, what is that? But,
Yeah, that's
but yes,
it.
we've come far, and I think, and we can tell the audience too, CAT scans, they're quick, they're easy. They show blood a little bit better maybe than an MRI, a little bit faster maybe.
Yeah.
And maybe they would get that when they go to the emergency room, but probably MRI is superior for
MRI is definitely superior. I'll tell you, the CAT scan, as you mentioned about blood and how it shows blood products better, it's only in the first 24 hours.
Yeah.
So acutely in the first 24 hours, you get a CAT scan. Worst headache of your life, you get a CAT scan. Easily accessible, fast. The problem with it, as I said, one thing about it is radiation. It's approximately 80 x-rays in one CAT scan.
I knew that, but I forgot.
And yeah, it's
80. Okay.
I think it's a hefty number, and how many patients are getting that across in the U.S. is alarming.
I feel like they're doing it less. At least in New York, I feel like it's a little bit less, and it is much more for the thunderclap, crazy headache, the worst headache of your life, or you're skiing and you fell,
Head
and
injury.
you have mental status changes,
100%.
you're out of it, all necessary. But yes, I do.
100%.
I think even from the time we trained, it's a little bit less maybe, the CAT scan.
Definitely, yes. Since we've known the radiation exposure to it. Most scans don't need contrast either. Even an MRI doesn't need gadolinium, and we use that different than contrast, but still don't need it. But that's the biggest difference, is the first 24 hours of someone having a head injury, having the worst headache of your life, and you say, okay, I'm here, what are we going to do for you? Let's make sure you don't have an acute bleed. And
Okay.
the CAT scan is a great way of doing it. And most people, it's not, of course, it's not invasive, prefer it versus a lumbar puncture,
Yeah.
right? I mean, a lumbar puncture is the next option, where if that's, this CAT scan's negative for blood products, subarachnoid hemorrhage, what are we going to do next? Lumbar puncture. And who wants a lumbar puncture?
Yeah.
A big needle put in their
the
lower
back of the
back,
spine, yeah.
and getting to make sure that there's no blood products in your spinal fluid. So it's a quick, easy, I wouldn't say cheaper, believe it or
right?
not.
It's
No.
not, right?
No. CAT scan it costs anywhere from 180 to 250 is the cost of a CAT scan, really, without just of the head.
Okay.
Where an MRI without gadolinium, average cost I'm talking about outpatient centers,
Yeah.
is around 280.
Oh, I didn't know that.
Yeah, so
I
it's
think they're
not
charging
the
more in New York.
delta difference with having, in my opinion, more answers. It takes a little longer, but no radiation exposure.
Yeah, so let's get into that,
You
because
know?
patients always want to know about that. So absolutely no radiation exposure, which
Mm-hmm.
I have many patients that still come in and it's not their fault, but they're like, I don't want radiation, I'm not getting in the MRI. So there is no radiation with
No.
MRIs. I don't know if you want to get into the maybe 2-sentence quick and dirty about how it works. Proton excitation and
Yeah.
many series of, it actually shows us like water movement in the brain, right? So we can see different tissues, which is amazing. And again, you know this better than I do, but you can visualize the back of the brain better. We can see a lot of. It's
Well, the
amazing.
deep parts of the brain you can see better. You can differentiate between this might be a little too much, but white matter,
Yeah.
and
The cool stuff, yeah.
yeah, I mean the cool stuff for us.
Yeah.
I don't know how cool it is us nerds, I guess you
Yeah.
want to say. A little, but I looking at different structures of the brain and looking at the cortex and how it's differentiated in regards to the atrophy of it. The MRI, we have different now sequences that
Yep.
we look at. I mean, just like a camera, I tell patients you can have sepia. You can, before it was just black and white, and now we have the color. So we're seeing that in imaging. I mean, even with CAT scans, we have reconstruction of CT scans.
No, those are amazing images.
Yeah, those reconstruction of the
Amazing.
vessels. I mean, that's amazing. Just recently, CAT scan was superior, looking basically at blood vessels and
Yeah.
looking for venous malformations or aneurysms. And MRA has come a long way, without again being exposed to radiation, because that's even more radiation
Yeah.
with the CT angiogram. No need for contrast even or gadolinium with the MRA, and you could see the
Yeah, it's
aneurysms. I mean,
amazing.
we've come such a long way recently over the past few years that we do a special sequence just in the MRI of the brain that we do a coronal T2 sequence, it's called, that I call a poor man's MRA.
Yeah.
So
So
that can
coronal, so
tell.
everyone can. So it's like if you're basically taking a slice, kind of, it's going to be this way, right?
Well, coronal is looking from front to back,
Yeah.
basically,
So
right?
it's like taking
So
a
you're
slice
slicing-
this
yes.
way. Yep.
So
like
you have
vertical
coronal,
slice. Mhm.
where you're looking from front to back, or vice versa. You have sagittal, where it's looking from sideways
Yeah.
and slicing across
So
from
there's-
right to
yeah.
left and
So there's
right,
many,
and
many
backwards.
ways to reconstruct it.
And then you
get
have
good images.
axial,
Mhm.
and those are the three. And you could do that even with CT now. We did when we had
Oh
it.
yeah, that's true. Actually.
Yeah, now you could
the
do it all
reconstructions are
3D.
Yeah.
But the MRI does show in the axial, and the axial is the most common way to look, the first thing. But sagittal is important, where you're looking sideways, because it gets slices that go through the spine where you can't see the spine. Even though it's a limited amount of the spine, it's more the upper cervical spine region that you could see in the sagittal view, usually around up to C4. But you could see the cervical medullary junction, which is the area of where the brain basically goes through the foramen magnum into the spinal canal. And people want to see that. We want to see that just to also rule out, that's where you look for Chiari. The best way
Yeah.
to look for Chiari malformation whole different topic. It's become very popular, I want to say. I don't know if it's popular.
I think what happened is, so first I want to say too that this is great information. And I think that as a doctor, I don't know how you feel, but I more and more like, yes, it costs money. Yes, it's time. Yes, you know, we're always looking to maybe save money and not scare people. But also we have this technology. And I feel like when people come in and they are worried that they, God forbid, have a brain tumor, an aneurysm, the only real 100% way to actually tell them they don't is to do one of these scans.
It's almost like just do it.
Exactly. So I kind of feel that way, and I practice medicine that way. And yes, it's defensive, but also people feel so much better after they have this scan.
It's a peace of mind.
It's such a peace of mind. And truthfully, I mean, how many people, like these are good numbers too, how many people with migraine have something horrible, like an aneurysm? Like, it's like very low percentages. Very low percentages in the single digits, I would say. I don't know the studies exactly, but I would say very low percentage. So utilizing these is amazing. And also, this is how we learn, you know, this is how we can do these things. So
the unfortunate thing is there's incidental findings that we find, right?
Yes.
But, you know, you tell the patient that. And a lot of patients come in to specialists not just for wanting some medication to deal with what condition they have.
Yeah.
Right? Many of them don't come to us and say, you know, I want a medication. No, instead they say the opposite.
Yeah, I
don't want any
Constantly.
medications. And I love that, in my opinion. And, you know, the first words out of my mouth is I'm not a physician or a provider who's just going to throw pills at you. You know, one, I'm here to diagnose you with hopefully the appropriate diagnosis so you understand it. But two, make sure you have a peace of mind when you leave my office, knowing that, you know, your exam may be normal, your headaches may be typical, and
your
what's
scan
typical.
is okay.
And then the last question is, are you eligible for an MRI of a brain to give you a little peace of mind? Now, coming from a family that has had, you know, tumors, unfortunately, and aneurysms, right? I mean, how many people do we know now have known someone that doesn't have that? It's rare. That doesn't have something. So they're always going to think about it. It's always going to be like on their mind. Oh, they all had headaches. Well, headache is so common. They feel like that headache was part of their brain tumor or part of their aneurysm. When you and I know that it's really not.
Wasn't.
Most of the time, headaches are not a symptom of a pathology that goes on in the brain,
tumor.
Unless the aneurysm is ruptured. You know, and then that's one of the worst headaches of your life. It's a different kind of headache. Unless the tumor is slowly growing or growing faster, you're going to have other symptoms other than headaches. Like one, for example, you know, God forbid, a seizure. That's very common that we see as something pathologic in the brain, more common than basically dealing with a migraine or a headache, kind of a headache disorder. That's in the primary headache disorders, which, you know, we could talk about primary and secondary. But going back to imaging, again, getting an MRI is basically you could get an MRI without gadolinium. So again, no exposure,
and you can rule out
and you could rule out a lot of different things.
Tumors, MS, demyelination, infection, big major things. And what's the size of the aneurysm that you can see on just an MRI? Brain without contrast. So not even the MRA. So the MRA, for folks out there as well, is actually a visualization of the blood vessels specifically. Just not everyone knows that. So
and the MRI is tissue.
MRI is a tissue.
MRI, tissue, MRA. But you know, you have these different sequences in the MRI that you could see the blood vessels.
Exactly.
But the sequences have to be cut in certain way. So, you know, we have 6 MRIs basically. We know different sequences, but there's different cuts. So 3 millimeters a minimum to look. I mean, you could have 1 millimeter slices, and you could visualize that better. But a lot of times, a lot of the aneurysms that we think about that need maybe some sort of intervention or even an evaluation by a vascular surgeon or neurosurgeon to evaluate has to be at least 3 millimeters or more. You know, that's, you know, it's not a rule, but it's something that, you know, guideline that we kind of look into and how dangerous they can be. That's 3 millimeters. Anything larger, then get a neurosurgical kind of evaluation. And then most of the time, what neurosurgery tends to do is serial scans, right? So you get like a scan in 6 months, And then if that's stable after 6 months, maybe in a year, after a few years of doing it yearly, then you may graduate to a 3 or 5 year kind of scan. So, surgery is not always the option when we tell patients, because that's another thing, right? You don't want to scare the patient, say, I'm going to send you to neurosurgery. And all of a sudden they're like, wait, I'm getting surgery?
Yeah.
And, you have to explain that this is just to get you
Survey,
in there, get their evaluation, what they think of it. They see this more often. We just diagnose and we almost ship.
Yeah.
And just have a team together, God forbid anything else happens, right?
Yeah.
So that's the majority of the time. So a lot of our patients that come into our office, what I see 98% of the time is, and that's when you say, how common is a patient that comes in and sees us who has abnormalities that are causing the headaches, less than 5% for sure.
Single digits
and
for
so,
sure. Me too. But
what
we do see,
right?
thankfully for sure. But what we do see, and I want to talk about this because I always change the verbiage in how I speak about this. What we do see is a lot of incidental things, and probably most commonly are the elusive white matter changes, and the thing that people don't know that I tell them is, like, in neurology we used to call these UBOs, which literally stands for unidentified bright objects, like literally like like the TV show, right? So you're the neuroimaging specialist. So what are these? I mean, I know we don't have an exact answer, but let's get into that a little bit, because that's what we do see most of the time.
And that's what you'll see in majority of patients. And nowadays we're seeing it a lot more often. I mean,
we are, right?
I would say, again, close to 98% of our patients who we image will have
something.
These T2 changes.
Yes.
What they call T2, even if it's just one. Okay.
So again,
and how
for the
great
audience,
technology, and I'll tell you how I explain it of what it kind of means in my opinion.
Okay.
But I'm going to tell you how it's so common that, because technology I think is getting better, that we're seeing, and we're getting better slices through, that we're seeing these T2 changes now.
And more resolution, right?
Better
on the
resolution.
Scan. So we're looking further in, and we're seeing these tiny things that we would have not seen before. Some people call them small vessel disease. What they are is T2 hyperintensity. We go by hyperintensity for MRI versus hyperdensity, or so density versus intensity for CT versus MRIs, and that's just technical stuff that nomenclature that we deal with more often. But for the public, these T2 hyperintensities can scare the crap out of someone who just reads it. Well, first they read it, but then they put it into the Google.
And then which is even worse.
Yes.
But,
I'll tell you what it says
Google,
in the Google.
But
I'll tell you what. Yeah, but you tell us what it is first, because that's.
I'll tell you what radiologists or neuroimagers or someone who just reads them quite frequently and comes in and sends it to primary care if they ordered it, and they get the report, which tends to give a differential that will scare the crap out of you.
Yeah.
Even without Google. Yeah. Right. What is this small vessel? Is it differential includes demyelinating disease.
So that's MS. Small vessel demyelination is ischemia. They often use the word ischemia, so that means a stroke.
Yeah.
Vasculitis is often on there.
It's a very big one, which is
rare. A scary, super rare.
Super rare.
Yeah.
But scary if someone reads it or someone looks it up. And these differentials are, they're there. They're part of the differentials. I get it. And then if hopefully someone's nice enough to put on there that you can also see it
with chronic migraine,
with
right?
migraine, right? You can also see it with a history of having migraines, and we see that. So how do I explain this to patient in lay terms? I'm gonna simplify it. In my opinion, and no one's taught me this, I just came up with this on my own. So how scientific is this? That's debatable, but
probably good.
Thanks. But I basically say, the deepest part of the brain is supplied by small vessels.
Okay.
And these small vessels can die off and scar the brain.
Okay.
So just like we get scars in our body, we get scars in our brain. But scars in the brain can be caused by a lot of different things. And it's important to understand them, because if they're scarred, they're there, they're not going to go away. They're not going to get smaller, but you may get more. But these are my main, things to concentrate on. The worst is smoking.
Mm-hmm.
Okay. Second, in my opinion, is diabetes.
Okay.
Third, and then the rest is not in really big order.
Probably hypertension.
But hypertension, cholesterol, hypercholesterolemia.
So I think the first three, just not to interrupt right away, but I think that, again, I do the same thing. We actually say very similar things. Listen, when they go into the pathology lab and actually look, we don't have so many brains to look at, right? In the growth pathology lab, what do these things actually look like? They don't look like much of anything, right? It is exactly what you said, a scar almost. So what is it? When the blood vessels taper off, they get smaller and smaller and smaller, and blood is not potentially reaching that spot, right? So what does that? Smoking hardens those arteries, so does high blood pressure, and so does diabetes. Yeah, diabetes does that, maybe indirectly, but maybe there's something with sugar that does that. But those, I think, are the major things.
Inflammation.
So I don't know if you were going to probably get to that, but inflammation past infection, right? That was like something that we thought about, and now after COVID, we think, I'm seeing more of it. I don't know if I'm seeing more of it or it just feels like I'm seeing more of it, but, more white matter changes.
For sure.
So,
well, one big one is migraines, part of it. We see it. But do you
know of any reason for that? Because I have not read about any. We don't know, right?
We don't know.
Like, why would migraine do that?
And we're still studying it, and I'm trying to get a bigger study together to see, how, which common areas in the brain that we're seeing it.
That'd be cool. That'd be really cool.
But from my clinical experience, because I read everybody's MRI while I see the patient, which is
patterns,
so I'm just not a radiologist or a neuroimager, I should say. I'm also the clinician to see, so I could put the patient to the picture of the brain.
Yeah.
So I've done that, for many years now.
So you're seeing patterns?
I see patterns, and no one's done really big studies on this.
Do it. That's awesome.
And since we see so many, one day I'll put it together in my lovely spare time to write up papers. But we'll it's getting there.
Okay.
I do have some thoughts, but I would like to say. Please don't worry. These T2 changes can also be part of a normal aging brain.
Process. Yep.
A normal aging brain. In fact, normal aging brain, that everything that we just named, if you don't have it, it's just age. So what are modifiable risk factors? The modifiable risk factors are the ones we just named, except age. Some people think, there's a fountain of youth that you may modify that, but there isn't, right? We can't modify, and the percentage is it's alarming. It could be up to 10% of patients over the age of 40 are going to have these T2 changes without having anything we just named, not even migraines. Just anything, right? And as you go up, even over the age of 60, that percentage goes up to even 40% of them. So it increases as we age. So what does that say? It says that please try not to worry about them. There's certain areas of these T2 changes that the radiologist or neuroimager who's reading the scans hopefully will say, and when they do say this, maybe then you think about, okay, I need to see a specialist. These are more consistent with demyelinating disease, such as MS, and that's usually if they have a history of it. Then the neuroimagers will see it, and then it's important, to see, are there new lesions there? And it's basically that demyelinating disease, just like what it says, it's hitting the myelin, the sheath around the nerve, and just kind of eating it up and showing the scars in certain areas. And there's certain areas in the corpus callosum, the division between the right and left hemisphere. You see these lesions pop up there. That's, a little bit alarming. But otherwise, majority of the time, for the audience, please try not to Google or worry about it.
Thank you.
And
one big question I get is that, and it's an interesting one. It's thoughtful on patients' part as well. Is, well, if I get more of these, what does that mean, right? So you probably get that a lot too, right? So like in my mind, I'm thinking, okay, you don't want more, right? You don't want you don't want a lot of these white matter changes, because what could happen in my mind is, like, with a lot of those, like a brain that has a lot of those risk factors and a lot of those scars, like, is that going to lead to neuronal death and, atrophy in the future, but I don't know the answer to that.
Yeah,
So
so how I explain it is basically the smaller vessels kind of die off.
yeah,
What goes next?
the medium-sized
The
vessels.
medium or bigger
Yes.
vessels, and those have a lot more control of big parts of the brain
Mm-hmm.
that can lead to stroke. So we know in studies, of course, that showed patients who have a history of hypertension, diabetes, any smoking increases your chances of strokes, and that's one of the big reasons. So again, I tell them, try to control what you can. Make sure your blood pressure is under good control. Make sure stop smoking. If possible, we can help with that. But it is an alarming thing to think about when patients say, "Wait, so my grandmother or my mother or father, unfortunately, also had these that they were told about, and they ended up having dementia." Dementia is the big one, right?
Yep.
That they think about, and unfortunately, dementia is becoming more and more common, and that's a whole different topic that we're seeing it more and more. Just
Yeah.
like what we're seeing, in my opinion, Alzheimer's dementia is a different type of dementia. Dementia is an umbrella, right? And then Alzheimer's is a piece of it. Again, we're looking at Alzheimer's dementia as what migraine was when we first started. 68 million right now Americans, and we're in the future. And not to scare anybody,
Yeah.
but we don't know what it means with these T2 changes or small
No,
vessel
we don't.
disease. But what we do know is risk factors that lead to dementia, not Alzheimer's specifically, but a type of dementia or cognitive deficit. Risk factors are everything we just named.
Exactly.
That we do
Yeah.
know. So
We do.
control what you can. That's my take-home message. Age is different. That's it.
Yeah, and I wonder if those numbers, I think they're going to get bigger as well. One, diagnostically, we're going to get better at it, but also just there's a much bigger population, and there's a population that's living 10, 15, 20 years longer than I think people used to, and they're living with those risk factors more than they used to. So more hypertension, more obesity, more diabetes, all, big swaths of the population have that, and it's it's potentially leading to this quote vascular dementia that you're talking about, which that's unfortunately I also agree. I think we're going to be seeing more and more of that. Hopefully not, though.
Yeah, and
Hopefully
vascular
not.
dementia is great. You brought that up. I can't believe I didn't say it, but yeah,
No.
that's a piece
You
of
did.
the T2 changes as we see them. If we're seeing more and more, and they're having more and more cognitive deficits, that's part of the vascular dementia picture. Some say, well, at least it's not Alzheimer's. It's still part of dementia. You're going to see
It's
cognitive
just
deficits.
as bad. I mean, it's just as
Yeah.
bad. It's the same. So I think, we need to worry about that. What do-
Disease modifying is very important, right? For
Yeah.
any of the things we just named. So that's all you have control of as a patient. We have control of as providers to help our patients with medications. But in my opinion, it's education.
Yeah.
I mean, I think it's the biggest piece of what we have to give to patients is educating them and reassuring them.
Yeah.
So understanding to take care of those risk factors.
Let me ask you this. So how do you feel about this? I have been starting more to tell people that I don't like that they get so many headaches. And I don't go as far to say that it could cause white matter changes, but some of the people that were my mentors in the past, they would say that as not as a threat, but as a something
Yeah.
if you keep getting headaches, you can keep getting more of these white matter changes, which don't worry about, but why would you want that in your head, right? So do you ever,
Or you better listen to me.
yeah, exactly. I mean,
I'm the doctor.
I'm not so forceful like that as a doctor
we're
either,
not.
but it's an interesting thing, right? It's kind of like maybe we should be looking at that a little bit as well, just as a guideline or as I don't also push medicine so hard, but I don't want people having these headaches all the time because it affects things downstream, and I'm wondering if it's causing some of these white matter changes. It is, right? In some people, and I don't want them to have that.
It leads also to bad habits. I do agree. I don't say in the beginning.
Yeah.
When a patient first comes in, I'm not gonna tell them. I tell them, listen, you have one migraine a day or one migraine a year. I'm sorry, but I have to give you a migraine specific medication that's prescribed, but it's only as needed.
Yeah.
I'm like, I don't want to be that kind of doctor. I have to give you a medication, but please listen to me that I have to give you something only as needed to treat your migraine. And if I get that face of they're doubting
Yeah.
that they really don't want anything, Then I bring up the fact that we know and we've seen in MRIs and imaging that when patients don't treat their migraines with a abort rescue medication that's migraine specific, and again, those are only prescribed. There's only 4 classes if we want to go through that, but there's only 4, and that are migraine specific, level A evidence to, I want you to treat it because you could get some scars in the brain. It could cause, it may cause,
It may cause.
we don't know exactly, but
Yeah.
it may cause scarring in the brain. And so it's just important. And not only that, I tell them, but it's important to treat it. And why would you want to suffer with that pain? And if you do, it starts automatically. We know that we showed in studies that it starts to become probably less frequent and less intense.
Yeah.
If you treat it appropriately,
Yeah.
versus going to sleep and trying to sleep them off, or taking over-the-counter medications that, in my opinion, have more kind of side effects than the prescribed migraine medications, especially with the ones that we have nowadays, the newer ones. So there's a lot to be said with, I don't think you need a daily medication. I don't think I want it, not everyone needs that. In fact, the studies, 40% of patients only need preventative, which is a daily, quarterly, or monthly kind of medications that we have on the market. But you definitely need a as needed.
Yeah.
Then we go through that and why that's important.
Okay.
But that's what I want to specify, I think, in my opinion, in relation to the imaging. More important than even getting the MRI. Let's make sure.
For sure.
Right?
For sure. But I
And
think
then,
it hits it
what
home
if
a
you
little
don't need
bit.
an MRI? What if, you just prescribe them a migraine-specific medication and they have a migraine and it goes away and they come back, oh my God, this is amazing. I don't need the MRI now. How many times has that happened?
That
That's
happens
happened if you...
often.
Yeah. 30,
40% of the time.
Yeah.
In my practice,
Unless
Yeah.
the patient says, I definitely need one MRI like now.
Yeah.
And again, we can't get it now. We're not the emergency room, unfortunately.
Well, even in the let's be honest, even in the emergency room,
You
you
don't
can't
get
get
it
an
now.
MRI.
Yeah.
You don't get it now.
There's people wait days in that,
Yes,
just to get their MRI.
I know. It's crazy. Yeah,
But
it's
don't be
crazy.
alarmed. Thankfully, most of them are normal.
Yeah.
And if you find incidental findings, try not to Google it,
Yes.
or
Or ask
trust
your friend about it.
Dr. Ravitz.
No, I think you should trust Dr.
Make sure you
Saikali.
call and get in here to this beautiful office here.
Thank you. Thank you.
But we treat patients. You and I think practice very similar, right?
Yeah.
I think that's why we pass the boards together. We got those boards. But we
It's
we
traumatic.
treat
It's
patients
very
like
traumatic.
family, right?
Yeah. No,
that's
I
how
think we
do.
have to.
I love my family. I'm not
Yeah.
gonna,
Yeah. I think it's.
if they're
We're
worried,
lucky.
we're
lucky,
there.
and if we're worried, we have to. That's
But
a
again,
big part of our job. A big part.
a barrier, if we want to talk about barriers, a barrier is basically, getting it through insurance and doing prior authorization, right?
Yes.
And that's a whole different topic, but I would like to just mention that's the biggest reason, they get CAT scans because it just goes through because that's what they're used to. But getting an MRI, again, going through whoever's ordering it and going through insurance, if they deny it, once they deny it, the patient's able to pay out of pocket now if they want, right?
Yeah.
Again, and shopping around, seeing imaging sites, other than the outpatient imaging centers, are averaging anywhere from, without contrast, 280 to 350, I would say.
It's higher in New York City, honestly.
And maybe,
it's higher.
but
It's
if you
definitely
shop
higher.
around, I mean, our charge is around 280. I'll tell you
Wow.
that, and that's
Okay.
what our charge is. And we do see a lot of Canadians who actually come across.
Huh.
It's only half an hour away, so that's why we have a high
And they
volume,
pay.
and they pay the cash, and we're giving care. We're giving, in my opinion,
No,
proper
that's real
care.
That's
right?
proper care. That's proper
it's
care.
a
We
piece
have
of-
this
even if it's just a
technology. That's
piece of mind.
the sort of progression of science and medicine is to offer care, and that costs money. That's just how it is.
Yeah,
So
imagine the ER visits. If someone doesn't get any imaging, and
it's still $1,200.
no, well,
at least.
nothing against ER. They have to make sure they do all the testing appropriately. I'm sure, but they keep going to the ER with a headache, and if they don't get that imaging done, they're going to keep coming back with any headache they have, thinking something's going on.
Yep.
They don't know. We know,
Yeah.
but they don't.
No,
so
but they go
so
repeatedly.
it's a peace of mind. I think once they get the MRI, you tell them there's no tumors, there's no strokes, nothing that's causing your headaches. They have some time before they say, okay, this is now a different headache, I'll go to the emergency room now again, get imaging done. And then they get the blood work. Of course, they have to make sure they do their due diligence in the emergency room. And that costs healthcare money, I think, more than an MRI machine would have cost in the beginning.
Absolutely.
You know?
More.
So, and patients feel better about it.
Yeah. So maybe we'll segue a little bit. What are you excited about in imaging? Like what kind of future study? You're in this more than I am, and I mean I can give you my opinion a little bit. It's you know, it is pretty cool what's happening. Like maybe we'll, you know, volumetric studies, DTI, like maybe a few of these things would be interesting. Do you guys do DTI? Okay,
we
so
do spectroscopy, we do TDIs. I mean, there's a lot of different sequences, you know, that we able to do now to look for a more detailed kind of imaging, to even look and map what parts of our tracts in the nervous system are affected by a brain tumor, and what parts does a brain tumor go through in the brain, so surgeons can map that out, and being able to resect the brain tumor without affecting certain tracts that can affect your motor, sensory, or you know, things like that. But
so it's looking at the just for everybody, and for me too, actually, they're looking at DTI is actually looking at the connections, right, between the neurons, so you actually see where it's connecting, like a path.
Yeah, so it's a diffusion tensor imaging.
Too, yeah.
You know, that's what it stands for, diffusion tensor imaging. And it's a lot of more technical. I think it's too technical for this. But in my opinion, what I'm excited about the most is susceptibility weighted imaging sequences.
Okay.
And that came out while I was doing the fellowship. And I was very interested in traumatic brain injury. So that's also what I do. I also see patients, because it goes hand in hand. Traumatic brain injuries, concussions, you know, you could call them whatever you want, but those are interchangeable in my opinion. Concussion, traumatic brain injury depends on how bad, you know, of a brain injury they had. We call it severe concussion. But anyway, I was interested in that.
What does that do?
SWI is the most sensitive that we have. We used to have gradient echo. It's another sequence to look at calcifications and blood products, and that was what we had best until, you know, I guess 2009, a little bit before that when it came out, but I was introduced to it at that time. And it's more sensitive and specific to looking at iron depositions or blood products, or even diffuse axonal injury. Okay. So that happens in a severe traumatic brain injury, even in deep parts of the brain.
And just to clarify as well, so on a regular MRI, we wouldn't necessarily see that, correct? No. So that's key, right? Which is very cool. So, you know, I remember this is your field, but I remember they were doing a lot of people coming from Iraq and Iran. Mm-hmm. MRIs all essentially normal, occasionally some bleeding or bruising, but really normal MRIs, and then these scans came along.
Or T2 changes.
Yeah, or
again,
that, yes.
Actually, it's part of a differential T2 changes is closed head injury.
Yeah, but also, you know, we would see these very abnormal, you know, SWI and DTI imaging, which basically, you know, the neurons were disrupted, which I think is, first of all, validating to a patient who had something horrible happen and the MRIs or CT scans were normal, and we're learning a lot. Like, we are learning a lot. So
the question always is how is it going to change management? In my opinion, it does. It changes, I think, the plan of care.
Okay.
Their future. I think it changes, you know, depending what parts of the brain are affected. You understand that their personality may be different. Their
which was
memory
often
may be
ignored
different.
Because when it was a clean scan and they had these sort of nebulous symptoms, people would not be accepting of that, right? Or jobs would not be accepting of that. So I agree with you.
Yeah, I mean, I would have loved to bring. I have a lot of samples of regular MRIs that they get, and then you add SWI, and you see where they had microbleeds and diffuse abnormalities there. Even in vascular structures that are abnormal, like AVMs and
like in the surrounding tissue,
arteriovenous malformation, which is more dangerous. Developmental venous anomalies that you see without needing contrast. You don't need contrast because you'll see it on SWI. So still don't need the contrast, and you could tell that it's blood vessels. But DVA is not serious most of the time. I call it the birthmark of the brain, basically, versus the AVM. AVM is definitely a neurosurgery kind of evaluation and see.
So you're saying on SWI imaging, the tissue is also really damaged.
Mm-hmm. You could see the area where that is, where we didn't see it in normal sequences other than gradient echo. but that also wasn't as
We weren't seeing
sensitive.
that the neurons were damaged,
No,
which is
that we
basically
didn't see.
showing us a lot, right?
That- and we have
that's
a lot
really
more
just
coming up.
malfunction. Yeah.
And we have a lot more coming out, yeah, well,
Yeah.
or even blood markers for concussions, and
Oh, that's gonna
but
be-
that's still
yeah.
controversial. Again, studies are being done. There are a few papers on that, but it is important, I think, to understand concussions and understanding the symptoms when you don't have to even hit your head to have a concussion,
Yeah.
right? Any kind of whiplash, even movement, can cause a concussion.
Yeah.
Or again, what do we do about it? Is there treatment for a concussion? No, it is time. It is avoiding hitting your head again until it heals, and avoiding going into a post-concussion syndrome, which is a syndrome umbrella of symptoms that continue after a concussion. Those symptoms were supposed to go away, which is average 4 to 6 weeks, is what we know in studies. So avoiding hitting your head in that time frame is important.
Yeah.
And getting imaging to make sure there's no bleed or small bleed, especially in the elderly.
Yeah.
That's where imaging comes into play. Very important to get a CAT scan right away if you
Yeah.
have a head injury. And elderly patients, unfortunately, with the atrophy that can occur to our brain, can cause you more to, even if they fall or slip, they don't have to hit their head, and they could still have what we see
Torn
as
blood vessel,
torn blood
bleed.
vessels, bridging veins, which it's a vein, so it's not as bad as a artery bleeding,
Yeah.
obviously,
But
it's still bad. Subdural hematoma, that's what causes a subdural hematoma. And we see that because it's acute in a CAT scan. Yeah. But it's interesting, right? We
Yeah.
have modalities, and does everyone need these scans to be done? For the first headache, yeah, those are big red flags. First headache, worst headache, change in headache, localized headache, if it's unilocked to always being in the same place. Atypical auras are important. And then, of course, the common ones, if God forbid there's any kind of neurological deficits with seizures, have other disease states such as HIV, cancer, those are things that are red flags, and they have a new type of headache, or headache isn't improving with medications that we typically give, then it warrants an MRI.
Yeah. Agreed.
But
Well, I mean, this has been awesome. Do you think
we have another few hours, I thought.
at least 7 hours, right, to talk about imaging?
What else do you want to talk about?
Remember when we had to sit in residency? Well, I liked it actually when we sat and had neuroradiology rounds, and they just went through each scan and the patient. I love that actually. So you did an extra year to do that, right?
Extra year
wow,
to do that.
that's
Yeah,
cool.
to
That's
learn.
cool.
It was cool.
Yeah, well, I think
I love it.
Yeah, I can tell.
Thanks.
You're exuding it. It's nice. It's nice. So I'm so happy for you to come here. I learned actually a lot. I hope my patients won't Google things. I hope yours won't either. And yeah, I'm excited for the future.
Ask us.
Yeah,
We'd
ask
love
us.
to educate.
Yeah.
Part of the therapy.
Yeah, that's
right?
true.
Part of the treatment plan. And if you don't get educated about what you have, come see Dr. Ravitz. I'm sure she'll take care of it. But thank you for having me on the
You're
show.
welcome. It's been amazing.
It's amazing seeing you again.
Same.
And it's just a 1 hour flight away, and hopefully we see you more often.
Yeah.
And see you hopefully in Buffalo to get to see some the falls.
Yeah, maybe
And
I
the
will.
Bills, baby. We'll take it.
Again, I told
gonna
you I
take
have
it
no
this year.
idea who's even like playing or doing what, and I'm a kind of an athlete, but I don't know why. I just
Yourself.
yeah.
Yeah. Yeah, we're a sports town that
Yeah, of course.
that has faith and always believes.
Okay.
All right.
Cool. Thank you.
Thank you.